So I'm going to talk about airways disease, and here are the cases. And I think one of the most important things when dealing with airways disease is to think of the size of the airway involved. You can have tracheal involvement, something very central. You can have central bronchial involvement or bronchiolar involvement, and the differential is going to be very different depending upon the size of airway involved. So what's the size of airway involved, such as in this case, and then differential will follow. And then the distribution, particularly with central airways disease, I think that's very helpful. Is it more of an upper lobe distribution? Is it going to be symmetric? Is it really asymmetric? And then there may be a few other findings that may be helpful in further narrowing your differential diagnosis even further. So compare those two cases to this case where the findings are involving the airways but very different in their appearance because this is a different level of airway involvement. And many diseases can affect both the large and the small airways, but diseases tend to predominate in one or the other, and they tend to be very different diseases. So Rick talked a little bit about nodules, and we'll go over a little bit more about nodules in the context of airways disease. Here's another example. I think a lot of chest radiology is knowing when to be definitive about one particular disease or organism and knowing when to give a differential. In a case such as this, you don't need to give much of a differential because there's a very, very specific finding here that will narrow it down to a very small group of diseases that could cause the abnormalities. And then the last case, also an airways disease, but instead of giving lung which is opaque, the abnormal lung here is lucent because of airway obstruction. Okay? So let's go through each one of those. Again, diseases of the airways may affect the central airways, such as in this case of cystic fibrosis, or they may affect the very distal airways, such as in this case of hypersensitivity pneumonitis. And as I mentioned, you can have involvement of both, but usually one or the other predominates, and the diseases that produce central versus peripheral airways disease are very, very different. And so you should determine which airway is involved. The very central airway, the most central airway is the trachea, the bronchi, the more central bronchi, i.e. large airways disease, or the bronchioles, in other words, small airways disease. So let's start with tracheal involvement. You see a case like this, it's sort of a classic radiology pimp. I love this case because I love cases where the differential is a bunch of really bizarro diseases, or at least diseases you don't think together. You can see a nice example of tracheal wall thickening. So the first thing that you should ask when you see a case of tracheal wall thickening is, what's the distribution? Is it half a centimeter or a centimeter in length of the trachea, or is it in the entire trachea and the central bronchi? So diffuse or focal. Start with diffuse. Here's a nice example of tracheal wall thickening that goes from the upper trachea down into the mainstem bronchi. And diffuse tracheal wall thickening, the three classic ones to give you this appearance are sarcoid, amyloid, and Wegener's. And these tend to produce fairly circumferential tracheal wall thickening involving both the cartilaginous portion, which is the anterior and lateral portions, and the membranous portion, which is the posterior portion. In contrast to relapsing polychondritis, thought to be an autoimmune disorder against cartilage, and since the posterior membrane is not formed of cartilage, this disease tends to spare the posterior membrane. It's a very characteristic appearance. The rare causes of diffuse tracheal wall thickening are infection, such as aspergillus. My residents about 6 years ago or so used to talk about Klebsiella rhinoscleromatis, which is I've never seen a case. I don't think we've ever had a case. And they mentioned it as the first thing in the differential because it was a case on Aunt Minnie. And of course, Aunt Minnie rules the world. Inflammatory bowel disease, rarely. And then if you can say it, you could throw this in if you know anything about it. I practiced this for years and years before I could say it, tracheobronchopathy osteochondroplastica. So we see a case of tracheal wall thickening. We're going to want to know, is it diffuse or focal? This case was diffuse. Notice the very characteristic sparing of the posterior tracheal membrane. And that is going to be almost certainly a case of relapsing polychondritis because it has that typical distribution. There's no involvement of the posterior membrane. Here's an example of another disease that spares the posterior tracheal membrane. Notice there's not really any thickening back here, but the thickening is not only is it thick, but it's very nodular and very dense, i.e. calcified. And this is a case of tracheobronchopathy osteochondroplastica. I like to say it as many times as possible because it took so long to actually learn how to say it. Okay, to compare that to this case, which also was an example of diffuse tracheal wall thickening involving the central bronchi, but see how the posterior membrane in this case is involved. So that's not going to be relapsing polychondritis. That's going to be likely sarcoid, amyloid, or Wegener's. And then if you want to throw in some of those extra rare diseases like inflammatory bowel disease and infections, you could. But mainly those three you want to throw in, and that's a patient with amyloidosis of the airways. Now, if the tracheal wall thickening or narrowing is very focal, as it is in this case, you see this one focal area of very narrowed airway, and the airway above and below look normal, then it's a very different differential diagnosis. Mainly it's post-inflammatory and post-intubation strictures, essentially. Intubation by far most commonly, but you can see with other infections and radiation and occasionally Wegener's, which often produces more extensive tracheal abnormalities, may be more focal. You can think of other things, tumors of the trachea itself, like adenoid cystic or mucoepidermoid, or tumors outside the trachea, either invading in or compressing it, such as esophageal tumors. And then don't forget vascular rings as a cause of tracheal narrowing. So that's the trachea, pretty straightforward. Thickening or narrowing, determine if it's diffuse or focal, and then determine your differential based upon the distribution. What about the large airways disease? Here's a nice example on chest x-ray of bronchiectasis and bronchial inflammation. And the appearance of abnormal airways on a chest x-ray are depending upon their distribution with respect to the x-ray beam. So if they're coming at you or away from you, they're going to look more circular, whereas if they're running more superior, inferior, or medial lateral, they're going to look more tubular. And this is a nice example of many circular abnormalities. You actually can see probably air fluid levels in them in a patient with very, very severe bronchiectasis in the lower lobes, and it's a very symmetric distribution. There's several types of bronchiectasis, and this is an order of severe from mild and relatively short duration of abnormalities to very severe and very long-standing. So cylindrical, it's a mild dilatation of the airways, maybe a little bit of thickening, but not too bad. Varicose, where it starts to get more, the airways start to get more enlarged and start to have these kind of strictures intermixed with areas of dilatation. So this is a bit more chronic and a bit more severe. And then cystic, which is the most severe form of inflammatory bronchiectasis, where you get these very markedly dilated bronchi that look very saccular, have these big dilatations, and often have air fluid levels and a lot of impaction and inflammation. The last type of bronchiectasis is traction, which is not an inflammatory type of bronchiectasis. The first three are inflammatory types of bronchiectasis. Traction, which Rick talked about, is due to adjacent lung fibrosis, and I'm not going to talk about that anymore. So, which form of bronchiectasis is this? The importance of knowing those forms is, as you go from cylindrical to varicose to cystic, the length and the severity of airway inflammation increases. So cylindrical bronchiectasis is a totally nonspecific finding. I probably have it right now. I have a little viral infection. And Rick probably has a lot more than I do because he sounded worse than I did. But as you go from that cylindrical towards the cystic is very long-standing, very severe airways inflammation. There's not many diseases that do that. So while cylindrical and varicose are relatively nonspecific, cystic is a small group of diseases. And if it's lower lobe and symmetric, by far most common is post-infectious. Usually it's the childhood viral infection, adenovirus, that occurs, and then they get very bad airway scarring. Actually, their distal airways get scarred, and that's over time that prevents normal lung development, and the large airways become very abnormal. Ciliary disorders like primary ciliary dyskinesia, immunodeficiencies, and it makes sense why all of these represent very long-standing and severe inflammation in the airways. Ciliary disorders, can't clear your secretions or infection. Immunodeficiencies, you get chronic infections in your airways. And then there are a couple of disorders of the cartilage themselves, or the tracheal bronchial cartilage, such as William Campbell, which is absence of the cartilage in, I think, the 4th through 6th order airways, and then tracheobronchomegaly. So you can see it's another sort of bizarro group of diseases, but this is the differential when you see very, very severe bronchiectasis, cystic bronchiectasis in the lower lobes. And this was a post-viral. This kid had an adenovirus when they were 2 years old, and this is the sequela of that 30 years later. And that's what happens. Okay, here's an example on chest x-ray of some circular-looking abnormalities at the bases. Some of these look kind of nodular, probably because there's some impaction and filling of the airways with mucus. What's also striking about this case, I did not intentionally flip it. This is not photoshopped to be flipped. This patient has situs inversus, so a combination of very severe airways inflammation at the bases and situs inversus, and however you want to pronounce that, cartageners or cardigangers, I'm not even sure what the real pronunciation of that is. Okay, here's someone with more upper lobe predominant abnormalities. Notice how some of these airways you actually can see, they look tubular. You see two parallel walls there, so this is airway dilatation and inflammation with air at the center, and some of them look more like solid cylinders because they're entirely filled with mucus. But cystic bronchiectasis, more upper lobe predominant, when you see that distribution, almost always it's going to be cystic fibrosis. Okay, so we talked about lower lobe predominant. When it's more upper lobe and it's symmetric, usually it's cystic fibrosis. When it's more mid to upper lungs and it's very asymmetric, you think of ABPA or allergic bronchopulmonary aspergillosis. You can think of TB, which tends to be very airway centric and produces a lot of inflammation, so the airways can get very abnormal with active or old tuberculosis. Tumors involving the strictures, such as carcinoids, because they tend to be a bit more slowly growing, so it has time for that airway to get obstructed and dilated and filled with mucus. And then bronchial atresia will be the airway dilatation and impaction will be associated with focal lung lucency, sort of an Aunt Minnie, that combination. Okay, here's a nice example of asymmetric upper lobe predominant bronchiectasis. You can see the tubular nature. It actually branches. There's one branch there and one branch here. Looks very, very dilated, so we would classify this as cystic bronchiectasis. So we're going to think of things like ABPA, tuberculosis, some sort of endobronchial tumor. I don't see any focal lung lucency to go with bronchial atresia, although it's still possible. Here's the CT scan on this patient, just confirming the finger and glove. It's sort of like a long alien glove, I guess, but it is still a tubular structure with some branches. What is also characteristic about this, notice on the soft tissue windows that the impaction is very high density. So that's probably fairly specific for aspergillus, which accumulates calcium ions amongst others. And this is someone with asthma who has allergic bronchopulmonary aspergillosis. Another example of, we see these round lucencies within the right midlung. If you see those round lucencies at the center of an area of consolidation, you're going to call them cavities. But when they're not associated with consolidation, we're going to think they're probably abnormal airways that are dilated and inflamed. Here's the CT scan, just confirming that these are in fact airways because they look tubular. Looks like it's focal and more mid to upper lung. This is someone with tuberculosis, with active tuberculosis. Okay, so we talked about trachea, we talked about central airways, and again, the potent thing about central airways is the differential is quite broad for airways inflammation, but it's much more specific when you're talking about cystic bronchiectasis, very severe, long-standing disease. What about the small airways? Rick talked about the small areas a little bit. I want to go into a bit more detail. Here's a beautiful example of central lobular nodules. And what is characteristic about central lobular nodules? Well, if you look at the fissures, if you're not sure of the distribution of nodules, you always look at the fissures. And you say, are the fissures involved or not? If the fissures are not involved, the pattern is going to be central lobular. Notice how these nodules, there's a band of lucency on either side of the fissure. This is a beautiful example of central lobular disease because the center of the lobule is spaced away from the fissure. If the nodules involve the fissures, it's going to be either random or perilymphatic. So you'd have to use other things to determine which one of those it is. So a beautiful example of central lobular disease. And what lies at the center of the lobule? Well, the airway and the artery. Okay? So again, I'm not going to go through all these. I'm just going to focus mainly on the central lobular, where the nodules, here's another example where those nodules spare the fissures. They're about a half a centimeter or so away from the fissure. Very typical central lobular disease. So central lobular nodules, no subpleural nodules are present. And again, what is the differential? The differential is going to be fairly broad because it includes any of the small airways disease. So we're talking about small airways disease here, not large airways disease, or any vascular disease. But you can even further narrow it down by density of the nodules. And this is the more detail I want to go into. When the nodules are dense, i.e. soft tissue attenuation, that tends to be endobronchial spread of something, and that something may be infection, or it can be aspiration, or it can be tumor, as in the case of what we used to call multifocal bronchoalveolar carcinoma, which we now call invasive mucinous adenocarcinoma. All those spread via the bronchi. Okay? If the nodules are very ill-defined, i.e. ground glass opacity or GGO, it tends to be not endobronchial spread. It's inflammation surrounding the bronchioles. And diseases that do that, the most common two are hypersensitivity pneumonitis, because you inhale this organic antigen and you get inflammation surrounding the bronchiole, but not as much in the bronchiole. You get stuff filling those bronchioles. And respiratory bronchiolitis, a smoke-related lung disease where you inhale smoke and you get inflammation due to smoke inhalation. Very simple. And then don't forget vascular diseases. When am I going to think of a vascular, I have central lobular nodules, when am I going to think of a vascular disease? Mainly when it's symmetric or diffuse and the patient has acute symptoms. Edema, hemorrhage, things like that usually present in the acute setting, whereas hypersensitivity and respiratory bronchiolitis usually present in the chronic setting. And endobronchial spread is usually asymmetric or patchy or unilateral, whereas vascular disease are going to be diffuse. So diffuse distribution, acute symptoms, think of a vascular cause as a possibility. Nice example of central lobular nodules, ground glass opacity. So this is not typical of bronchopneumonia. This is not typical of an invasive mucinous adenocarcinoma. This is much more typical. This patient had 6 months of cough. So we're going to think mainly hypersensitivity, and we're going to look for exposure, which you only see in about 50%. And we're going to ask about a smoking history to see if they may have respiratory bronchiolitis. Here's an example of the opposite of that. These nodules are, notice how they're focally in the right lower lobe, so they're not diffuse. And there's soft tissue attenuation. They're very dense. This is typical of endobronchial spread of infection, aspirated material, or if they had, say, a year of cough, then you would consider an invasive mucinous adenocarcinoma. Obviously, the infections and the aspirations have an acute onset, whereas the invasive mucinous adenocarcinoma is going to be more of a chronic process. And this was just a regular old bacterial bronchopneumonia. Okay, another example. A nice example of central lobular nodules. See how they spare the subpleural surfaces? Eventually, when these nodules get big, they're going to eventually touch the pleura, but they're going to start, the center of them are always away from the pleura. You can see this is another area where they touch the pleura just because it's so confluent, but the center of the nodules are always away from that. You see some in the left lung as well, but look, soft tissue attenuation looks very patchy and heterogeneous. We're going to think endobronchial spread of infection, aspiration, or tumor if the patient has chronic symptoms. That was tuberculosis. Okay, here's another example. Notice in this area it's become very, very confluent, but in the areas which are not totally confluent, you see a nice example of central lobular nodules. That's about 1 centimeter away from the fissure. Here's another bigger one, which is about 1.5 centimeters or so away from the subpleural lung. Nice example of central lobular nodules, soft tissue attenuation. So we're thinking, infection, aspiration, but this patient had 9 months of cough and dyspnea and weight loss, and this was an invasive mucinous adenocarcinoma, or what we used to call multifocal BAC. Another finding which is very, very helpful in clinical practice is this finding, which Rick touched on briefly. This is a beautiful example of it. We see these branching, tubular, soft tissue attenuation things with nodules sort of along the courses of them. Notice how they are central lobular. How do I know? Because they are away from the subpleural surface. And we actually, in this case, we can see how these connect to more of the central airways. We can follow them back to these more central airways. This is a nice example of both small and large airways disease in the same person. Okay, so that finding is tree and bud. This is, my nectarine tree is just starting to do this. We have an early spring in California. As the buds start to swell, that's why I call it tree in bud, because the buds are starting to swell in the spring. And this is someone with primary ciliary dyskinesia. If I showed you more central lung, you'd see that the patient had really, really bad cystic bronchiectasis in other locations. What's the importance of this sign? As Rick mentioned, almost always infection. It represents pus in the airways, filling up those small distal airways. Almost always infection or aspiration, but infection, and if you want to get a diagnosis, it's generally in the sputum because basically you've got infections filling your airways, so the sputum analysis is usually yields something. Okay, so the differential is, I sort of break it into infections, and it's really any kind of infection. Bacterial, mycobacterial, viral, fungal, the common parasitic infection, of course. And infectious variants, which are essentially infections. So allergic bronchopulmonary aspergillosis is aspergillus in your airways. It's a hypersensitivity reaction to an infection. It's not an invasive infection, but it's an organism in your airways. Cystic fibrosis, Basically, you got infectious debris in your airways, you can't clear your secretions, and you get chronic infection in your airways. Ciliary dyskinesis, the cilia don't work, you can't clear infection, you have infection in the airways. Immunodeficiency, same thing, okay? So infectious and infectious variants, all the same. In most cases, in the infectious variants, other abnormalities will be present. In most of these cases, you have cystic bronchiectasis. Whereas in these cases, you may just have tree and bud and some central lobular nodules. That may be a distinguishing factor between these two. Okay, so here was one of our cases. Actually, a nice example of central lobular nodules, soft tissue attenuation. Notice how most of them spare the subpleural surfaces. This area has just gotten more confluent, looks kind of patchy and heterogeneous. And notice the tree and bud there in the left upper lobe anteriorly. That's almost certainly infection, although it's not specific with regards to the type of infection. This was an atypical mycobacterial infection. Okay, last pattern, and a very important one, is that of mosaic perfusion. Here's a patient with heterogeneous lung density. You have areas of lung which are lucent and areas of lung which are opaque. And the question you have to ask yourself when you see this heterogeneous lung density is the lucent lung abnormal, in which case the pattern is mosaic perfusion, or is the opaque lung abnormal, in which case the pattern would be ground glass opacity, and how do we distinguish those two patterns? There's a few ways. So I'm going to show you all cases of mosaic perfusion where the lucent lung is abnormal. About half of lung density is due to blood flow. So if you reduce blood flow to areas of lung, it will get darker. That's the sort of theory behind mosaic perfusion and why it looks the way it looks. And that may be seen with vascular disease such as chronic PE, and it makes sense why they get decreased perfusion because you have vascular stenoses and occlusions. And you also may see it with airways disease, usually small airways disease, and what happens in that case is you get regional areas of hypoxia, and then you get reflex vasoconstriction in those areas, and the blood and the lung becomes dark because of that vasoconstriction. And that's by far more common. Airways disease is much more common. So we distinguish mosaic perfusion, lucent lung abnormal, from ground glass, opaque lung abnormal in several ways. One is mosaic perfusion tends to be very sharply demarcated from the lucent and the opaque lung are very sharply demarcated from one another. I tell my residents it's like you took a cookie cutter in the shape of a lobule or a few lobules and just chopped out a part of the lung and made it dark. The vessels may be different in the lucent versus the opaque lung. In mosaic perfusion, they tend to be smaller in the areas of lucent lung because they are abnormally perfused. The perfusion is decreased. If you see this finding, it's helpful. If there is small vessels in lucent lung, you can be pretty confident the lucent lung is abnormal. If you do not see the difference in vessel size, you sort of ignore this because you'll see cases of mosaic perfusion where the vessels are equal in lucent and opaque. And then air trapping. Air trapping is seen in patients with airways disease, obviously, not in patients with vascular disease. But if the lucent lung on the expiratory images stays lucent, then you know the lucent lung is due to mosaic perfusion. And not only do you know that, you know it's due to small airways disease. So here's examples of all that. Notice on the first one how geographic those areas of lucent lung are. So sharply demarcated between lucent and opaque. Very characteristic of mosaic perfusion, so the lucent lung is abnormal. This is someone with bronchiolitis obliterans or constrictor bronchiolitis. Okay, an example of vessel size discrepancy. Notice how in the lucent lung the vessels are much smaller than in the opaque lung. The opaque lung here is normal because all that blood is now being perfused in this area. And this is someone with chronic PE who has mosaic perfusion. And then lastly, you can see the tan arrows show an area of mosaic perfusion on the inspiration, and as they expire on the expiratory images, the lucent lung stays the same density. That's abnormal. On expiration, the lung should normally become more opaque. Here's an area of normal lung, the blue arrow, and on the expiratory image, that area becomes denser. That's normal, okay? So this is mosaic perfusion here, air trapping here, in someone with small airways disease, okay? Okay. So a beautiful example of mosaic perfusion, one of the best we have, very, very sharply demarcated areas of lucent lung. That means that the lucent lung is abnormal, and this is someone with constrictor bronchiolitis or bronchiolitis obliterans, where you basically get scarring of your small airways. You get fibrosis surrounding your small airways. It causes them to be obstructed. You get hypoxia distal to that, you get reflex vasoconstriction, and you get decreased lung density from that perfusional abnormality. This is also someone with mosaic perfusion, but they have other findings. Notice the lung density is heterogeneous. You have opaque and lucent. So we're going to say the lucent lung is abnormal. Why? Because they're pretty sharply demarcated from one another. But I'm also biased by this terrible bronchiectasis and inflammation in the airways. And this is pretty close to cystic, if not right there. And this is a patient with cystic fibrosis. So you really can see mosaic perfusion with any cause of small or large airways disease, more commonly small. And it's very similar, the significance of mosaic perfusion is very similar to interlobular septal thickening. You ignore it unless it's the predominant finding, because mosaic perfusion can be seen with any airways disease. But when it's the predominant finding or the only finding, it's a relatively focused differential diagnosis, constrictor bronchiolitis or bronchiolitis obliterans, or obliterative bronchiolitis, whatever you like to call it, asthma, hypersensitivity pneumonitis, and then some vascular diseases as well, like chronic PE. Okay? Here's an example, heterogeneous lung density. Here's a beautiful one right here. Notice that's like a few lobules that are just knocked out of the lung. Looks lucent. There's the expiration. Notice how in the expiration the lucent lung stays lucent, and all this normal lung becomes more opaque. So that just confirms that the lucent lung is abnormal on the inspiration. It's the isolated finding. I'm going to diff this out as bronchiolitis obliterans, asthma, and hypersensitivity. This patient had or constrictor bronchiolitis due to smoke inhalation in a fire. Sometimes the inspiratory images are normal. This is normal. And then on expiration, you pick it up the air trapping. That's another very typical appearance of bronchiolitis obliterans or constrictor bronchiolitis. So that's why we do expiratory images, because we'll improve our sensitivity for small airways disease.